the Clinical Research Committee webinar series, webinar third, controversies to consensus. Today's topic is...
You are very low. Voice is very low.
Hello, ma'am.
No, your voice is low.
Jorag matters.
Yes, ma'am. And Arun, you have to record, no, to put it on YouTube.
Arun, are you there?
It started, ma'am.
There.
Yeah, sir said we will start. We'll start with a welcome and the prayer song. No, just start. Recording.
Start ಮಾಡಿ, ma'am.
Okay. Good evening, everybody. We welcome to the KSOGA CRC webinar series, which is the third webinar in the series, Controversies to Consensus. And this is planned for every second Tuesday, 5 to 6:30 in the evening. Today's topic is medicines, use and abuse in pregnancy. We thank our chief patron, our president, our past president, secretary, and treasurer, and of course, Jyotika ma'am and Sundari ma'am, who are the series judges, and Durga Das sir for having given us this opportunity. So we will first welcome this with a prayer song, and then we will have speech by Dr. Durga Das sir, and then we will start the proceedings of the webinar.
Kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatru buddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada.
Thank you. I request sir to give the president's speech, please. Thank you, sir.
Good evening, everybody. At the outset, I congratulate Dr. Srimati, the chairperson of Clinical Research Committee, for conducting this webinar. Because this webinar is the one which is very, very close to my heart. Because among the 2-3 projects of mine, this is one of the brainchild of my of me. It is coming out so beautifully under the guidance of Dr. Jyotika Desai and Dr. Sundari madam. Coming to the topic today, you have taken very practical topic. I have urged whomever I know, I have urged them to log in today, because this is one of the beautiful topics which have been chosen and required for each and every practicing gynecologist. Dr. Shilpa Sri from Bangalore, Dr. Nisha from Hubli Dharwad, Dr. Renuka from Haveri, Dr. Jayashree Patil from Basava Kalyan. All the best to all of you. Coming to Dr. Aparna Sharma, and she has not yet logged in, I think. I have very high regards for her. She also knows that, in fact. In conferences, whenever I have met her, I used to say, I'm a big fan of you. It's very knowledge to the core, which I appreciate the way of presentation. Not only knowing the subject, presentation is also important. That's why that's what I tell the youngsters. The youngsters who are coming to this platform, you are doing the fabulous job. You know the subject and you present so well. That's the second beauty of this. With this few words, I thank Dr. Aparna Sharma, who is going to join shortly, and all the best to all the participants. Thank you.
Thank you, sir. Thank you so much.
Thank you, sir.
Ma'am, shall I start the introductions, ma'am? Because Dr. Aparna...
Yeah, start. I'll call her again and tell her to join.
I'll do the CV
She has to judge
introductions.
the paper. In problem,
So I have great pleasure in introducing the judges and the speakers of this webinar series, Jyotika ma'am and Sundari ma'am, who have been the backbone. Jyotika, they both need no introduction. Jyotika ma'am is a senior consultant at Desai Hospital.
Srimati, leave it that every time you need to
Still, ma'am,
introduce her.
one word, ma'am, one word.
Just leave it. Just leave it.
Past president, BSOG, great teacher, Of course, Sundari ma'am
Yeah,
is an honorary professor and a very humble person and very inspiring to everybody. I think we have to take many a leaf out of your book, ma'am. So we're really very privileged to have you both with us. And of course, Dr. Aparna Sharma, who's joining us. She's a professor OBG at AIMS and she's a fetal medicine specialist with expertise in fetal interventions. She has had a master's in fetal medicine from Barcelona University. She's a secretary of SFMM and she's a chairperson of various societies, AOGD, Multiple Pregnancy Stillbirth Society, and she's got lots of awards and prizes and lots of publications. So it's indeed a great pleasure to have Dr. Aparna Sharma with us. And of course, the speakers who have been selected by their individual societies, Dr. Shilpa Shri from Bangalore. She's a HOD senior consultant at St. Martha's, a good friend of mine, EC member of BSOG, DNB teacher, thesis guide, and a very, very nice human being. Dr. Nishta from Dharwad. She's a clinical director at Jiva Fertility Center. She's got a fellowship in reproductive medicine. She was formerly an associate professor at SDM Medical College, Dharwad. She's got lots of publications and presentations, and her specialist interest is infertility. Dr. Renuka, she's a consultant OBGYN at Anant Reddy Hospital, Ravebenur, Haveri. Dr. Jayashree Patel, who really agreed in the last minute to participate. So really great thanks to Dr. Jayashree for joining us. Consultant OBG at Kadale Multi-Speciality Hospital, Humnabar. She's got her advanced obstetric ultrasound from Mumbai. And yeah, great having you all with us and looking forward to the webinar. Just to reiterate the rules, 12 minutes for the presentation, 3 minutes for the question and answers. At the end of 11 minutes, I will just give a warning. Dr. Aparna, thank you very much. We just introduced you. Thank you very much for joining. And Dr. Srimati, Durgadas sir also was really praising you. So thank you very much for taking your time out and joining us today. Really privileged to have you with us. So 12 minutes for the speakers, 3 minutes for the question and answers. I hope you have understood the rules. So I'll give you a warning at 11 minutes.
Hi, Aparna.
Hello, ma'am. Very good evening to all of you. My apologies.
No, you joined just in time.
Thank you so much. Looking forward to this.
Your introduction. That's all.
Thank you.
And this is Dr. Sundari, the other dad. Sundari?
Hi.
Yeah.
Hello.
Hi, ma'am.
Right. I think we'll start now. Srimati, come
Yes,
on.
ma'am. Dr. Shilpa Shri is going to be the
Yes,
first
yes.
speaker from Bangalore. She'll be speaking on low-dose aspirin. You can start screen sharing, Dr. Shilpa Shri.
Okay. Hello. Good evening to everyone. My slides are visible.
Yeah. It's visible, ma'am.
Thank you, KSOGA, for this opportunity, Sir, President Sir, and Dr. Srimati. And thank you for the judges, Dr. Sundari ma'am and Dr. Jyotika ma'am. My topic today is low-dose aspirin, whom, when, and how much. We all know that preeclampsia is a multisystem disorder which affects 2 to 5% of pregnant women, and it's also a leading cause of maternal and perinatal morbidity and mortality. Now, preeclampsia is also known to be associated with long-term risk for cardiovascular disease in both mother and infants. And now several studies have shown that prophylactic use of low-dose aspirin in women who are at high risk of developing PE could reduce the prevalence of the disease. A word about aspirin. It is N-acetyl salicylic acid, which is an NSAID, which acts by inhibiting the 2 cyclooxygenase isoenzymes COX-1 and COX-2, which are necessary for prostaglandin synthesis. Now, COX-1 isoform is present in vascular endothelium, and this regulates the production of prostacyclin and thromboxane A2. And this also has an opposing regulatory effects on vascular homeostasis and platelet function. The prostacyclin is a potent vasodilator and inhibitor of platelet aggregation, and thromboxane A2 is a potent vasoconstrictor and promotes platelet aggregation. Now, COX-2 isoform is inducible and it is upregulated to stimuli like exposure to cytokines and other inflammatory mediators. Now, as we know that aspirin in low doses, which is about 60 to 150 milligram, it irreversibly acylates COX-1, resulting in decreased platelet synthesis of thromboxane A2 without affecting the vascular wall production of prostacyclin. Hence, it was started because of its preferential inhibition of thromboxane A2. Now, aspirin in higher doses inhibits the COX-1 and COX-2, thus blocking the prostaglandin synthesis. There are some absolute contraindication for giving aspirin, like aspirin allergy, hypersensitivity to other salicylates and NSAIDs, or asthmatics with a history of aspirin-induced bronchospasm. Relative contraindications are GI bleeding, active peptic ulcer disease, and hepatic dysfunction. Now, several national societies have recommended that women who are identified as being high risk for preeclampsia should receive a low dose aspirin from less than 16 weeks at the dose of 100 to 150 milligram, which is the dose which is necessary to optimize the prevention of PE. But why 16 to 18 weeks? Because this reduces the deep placental disorder in women who are at high risk for poor placentation, and in turn, which reduces early and severe forms of preeclampsia and FGR. Now, coming to who are the people who are at risk. FIGO recommends that you do universal screening in early pregnancy, that is in first trimester, where the combined test is done along with the maternal risk factors and biomarkers like mean arterial pressure, serum placental growth factor, uterine artery PI as a one-step procedure. Now, Papa-A can also be useful if others are not available, and this screening can be adopted in twin gestation also. Combined screening between 11 to 13 weeks detected 76% of preterm PE and 38% of term PE. Now we have the gestosis score for the risk factors. Now, SGP gestosis score is a risk scoring system to predict the likelihood of a pregnant woman developing preeclampsia. It is a simple, cost-effective scoring which categorizes the women into low, moderate, and high-risk groups, and a score more than or equal to 3 implies high risk of PE. This was developed by Dr. Gaurav Mandrupkar. It was modified by a committee, and it has as a tool to assess the risk of preeclampsia. It assigns points for the various risk factors. Why it is used? Because of the pre can be detected early, and the targeted management would be low dose aspirin. These are the risk factors where they are assigned: 1 for minor risk factors, 2 for major risk factors, and 3 for high risk factors. So women with more than 1 or 2 moderate risk factors and 1 high risk factor, plus along with the measurement of MAP and serum placental growth factor and uterine artery PEI, if they found to be high risk for PE, then they need to be started off prophylactic aspirin from 11 weeks onwards, preferably better less than 16 weeks. This is shown to decrease the risk of FGR preterm birth due to PE. When to start? In a meta-analysis of aspirin versus placebo or no treatment, the prevalence of preeclampsia and FGR can be reduced by aspirin, which was started less than 16 weeks, and the effect is more marked for severe PE, leading to delivery at less than 34 weeks. And they also showed that aspirin started more than 16 weeks had no such effect on prevalence of severe PE and FGR. Now, these are the various recommendations. It started off by WHO in 2011, which told that we start low-dose aspirin 75 milligram per day to be initiated before 20 weeks for women who are at high risk for PE. And say in July 2013, NICE guidelines also recommended 75 milligram per day from 12 weeks for women at high risk for PE, citing that there are no maternal risks like abruption or PPH or any other fetal risks of congenital anomalies, ICH, or premature ductal closure. Now, ACOG and SOFM in 2016 also told that you start low-dose aspirin 81 milligram per day between 12 to 28 weeks, but preferably before 16 weeks, to be continued with delivery for women with more than 1 moderate risk factor. And they clearly said that it is not recommended for previous stillbirth in absence of risk factors, or for the prevention of FGR in the absence of risk factor, or for the prevention of spontaneous preterm birth, or for prevention of early fetal loss. Now, there's a meta-analysis from 45 RCTs in 2015, which showed that there was only a modest reduction in PE when it was started after 16 weeks, but there was a significant reduction in severe preeclampsia, FGR, when it was started before 16 weeks. And this has to be continued till 36 weeks or till delivery. Now, this coming to the ASPIRATE trial, it's aspirin for evidence-based preeclampsia prevention trial in 2017. It provided the evidence that aspirin at the dose of 150 milligram at night from 11 to 14 weeks until 36 weeks of gestation, as compared to placebo, resulted in halving the incidence of preterm PE, and preterm delivery rate was also reduced by 62%, and NICU stay was reduced by 68%. This trial detected 77% of preterm PE and 43% of term PE. The choice for recommending nighttime consumption of LDA was based on a RCT, which showed that women with low dose aspirin had a significantly lower hazard ratio of serious adverse outcomes like preeclampsia, preterm birth, FGR, and IUFT. So how much? So in 2018, a meta-analysis showed that there is a reduction of preterm PE by 70% if initiated before 16 weeks with a dose of 100 milligram per day. A Cochrane review in 2007 and in 2018 showed that aspirin greater than 75 milligram per day had a significant reduction in the risk of PE. Now, there is a dose response effect for prevention, which is like it can be given in this one 2.5 to 3.5 milligram per kg is the required dose. So in a 50 kg women, it comes up to 125 milligram, and a 65 kg women, it comes up to 150 milligram. So the various recommendations given by various committees are ACOG 81 milligram, RCOG 150 milligram, NICE guidelines 75 to 150 milligram, FIGO 150 milligram, ISS HHP 100 to 162 milligram. So according to these, 150 milligram per day is the most effective dose. Now, there's also an entity called aspirin non-responsiveness, which can be sometimes 40%, which can be attributed to non-adherence or non-compliance or platelet turnover rate, genetic predisposition. This can change with the change in dose, which improves the response to low-dose aspirin, like from 75 milligram to increase to 150 milligram. Once daily dosing is the standard practice, as the effect of aspirin is dependent on the rate of platelet turnover as exposed to half-life. A note, a decision to continue low-dose aspirin in the presence of obstetric bleeding or risk factors for obstetric bleeding should be considered on a case-to-case basis, and low-dose aspirin is not a contraindication for neuraxial blockade. So my last slide is the take-home messages. When to start low-dose aspirin? To be started between 11 to 14 weeks after the first trimester screening, and it's beneficial found to be beneficial when it is started before 16 weeks. And in all pregnant women who are at risk for developing PE by risk screening system and by first trimester screening. And the recommended dose is 100 to 150 milligram, which is recommended by various societies as once a day dosing, preferably till in the evening or mid-time until 36 weeks or till delivery. These are my references. Thank you for a patient hearing.
That was an excellent presentation, Shilpa.
Thank you, ma'am. Thank you.
All the questions. Can I ask Dr. Aparna to ask the first question to Shilpa, please?
So, Dr. Shilpa, nice presentation, very
Thank you,
nicely
ma'am.
summarized
Thank
the
you.
evidence.
Yes.
But I want to know that because this is a session on the promotion of evidence-based medicine, I just want to know that after aspirin, what is the more recent evidence? Have you heard about stopping aspirin after start? Do you have any experience, or have you?
Shobha, can you please unmute? Mute yourself.
So my question is that, you know, what is your take on the fact that if you have started aspirin and in the second trimester of pregnancy, the uterine artery Doppler is normal, would you consider stopping aspirin? So this is something which is called the stop-pre trial. So have you heard about it, or have you read about it? Or
No.
I mean, see,
But,
aspirin is something which has been around for some time. And there's also a very recent study which is called the aspirin trial, in which there have been centers from India as well. And it's a very significant trial which talks about the role of aspirin in prevention of preterm birth.
Yes.
So we are focusing on preeclampsia, but we must also think about the other things and whether aspirin has a role in that. Yeah. But good otherwise. Yeah.
No, once we have started aspirin, we have continued till 36 weeks at least. So whatever benefit we have to do. Actually, I've given my PG this topic that we are based on these maternal factors, like we following the gestation score. So we've started aspirin 150 milligram. So what is the risk, whether the preeclampsia is developed, and what is the rate of preterm birth, we have to see. I'm not sure about the trial, that one.
Okay. Thank you.
It didn't show any difference, basically.
Mm.
But stopping the aspirin also,
Yes.
when they noted the effects, it was almost the same.
Okay, ma'am. Yes, yes.
Okay, Aparna?
Yeah. So that's the point, right? So it has been seen that in the second trimester, you do a uterine artery Doppler. If that is normal, then probably your first phase of trophoblastic invasion is over.
Already
And
over.
probably
Yeah,
there is no
correct.
further advantage of aspirin. Because
Yeah.
these are some of the things that are coming up. In fact, there's an ongoing study which is talking about doing SFLT PLGF in the second trimester. That
second
is normal,
trimester.
then you stop aspirin.
Correct.
So these are some of the interesting things around aspirin, because that definitely giving aspirin throughout pregnancy will have its own complications.
Correct.
So that's again
Yeah,
something.
that is true, Aparna. A lot of more stories are coming up
Shobha?
around aspirin.
Wait.
Yeah.
Let us
Yeah.
finish the question time.
Yeah.
So can you ask the
So
next?
I think that was a very nice presentation by Shilpashri. Very well done. Thank you. Yeah.
Can I ask? Time is there, Jyotika?
We have time till
Yes,
to
ma'am,
do.
time is
See, you concentrated on prevention of the PE. Any other situations where aspirin is recommended now? Any other problems?
Madam, actually, in APLA positive patients also, along with low molecular heparin, you can give aspirin. That's what some
You
studies are
can give
there.
or you should give.
No, you should give. That
Yeah.
also will prevent PE
So,
in APLA
whom it
positive
is, the
patients.
question is in whom aspirin. That's a question for you. So you have to narrate all that. And what about, anyway, it has been discussed by Dr. Aparna about the preterm labor. Is it recommended? Suppose she has got a previous
ma'am.
preterm labor.
No, it is
Recommend?
not recommended.
No.
According to ACOG, not
Yeah.
only for to prevent preterm birth, it is not recommended. But
Okay.
only if she should have other risk factors, then only you can give.
Okay. Suppose she has got two miscarriages before and she
For
comes
recurrent-
third time. Is it recommended?
No, madam. Recurrent pregnancy loss also, it's not recommended unless she has any other risk factors. That scoring system we have to see, and uterine artery
Are there
Doppler.
papers on miscarriage, unexplained miscarriages, more than two? Is it recommended?
I
So
don't think.
I think your time
But
is.
we are in
Yes.
clinical practice, we are giving. But
There are some papers which
papers-
recommend for recurrent abortions also.
But
The
in
low dose
clinical,
aspirin up to 12th week, not beyond that, but up to 12th week it is. Okay.
okay, madam. Yes,
Well
madam.
done.
We'll have,
Good, yeah.
Ma'am, we'll stop
we'll
here.
have one more minute. No, one more minute to answer
Ma'am,
one
no,
question.
ma'am, 3 minutes are long over, ma'am. Okay, ask one more. Anyway, she
Oh,
finished.
yes, ma'am.
She
Ask, ma'am.
finished early.
Can you tell me whether folic acid is equivalent to 5-methyl tetrahydrofolate? Any differences between the two?
That is
Ma'am,
the
folic acid
Whom
should
you
be
are
done, ma'am.
asking?
Folic
Folic
acid.
acid.
purest form, which is more effective.
But it's not her topic, ma'am.
It is not the topic.
Sorry,
Good,
I'm sorry.
Hey,
Yeah,
Jyotika, it's not the topic. There is a topic on folic acid.
Yes, I know, I
Okay.
made a mistake.
Okay.
Okay, sorry.
Okay, then.
Yeah.
What about metabolized folic acid?
Folic
You,
acid.
my friend?
Hey, you're asking folic acid, yeah.
Again, I'm doing the same mistake.
Shilpa, suppose you have started an aspirin for her.
Yes, ma'am.
Okay, she comes with a bleeding,
Mistake like
Yes.
clotting. Okay, she's about 14 weeks. You had started at 13th week after the uterine artery Doppler, and she comes with a bleed. What will you do for her?
Madam, that's what it's written. You need not stop it, but then you should decide on the case to case. If the bleeding is heavy, maybe you can stop it. But if it is a light bleeding, you can continue.
Absolutely.
Ma'am, I will stop here, ma'am. We'll go to the
Yes.
next one, ma'am.
Yeah. Thank you, judges. Thank you for the
Thank you.
opportunity. Yeah.
Thank you, Shilpa. Next, Dr. Nishta on progesterones. Yeah, you can start, ma'am. Can she start, ma'am?
Yeah.
Good evening, everyone.
Yeah, you go to the next
Dr.
slide,
Nishta.
Doctor.
At the onset, I want to thank team HDOGS from Hubli Dharwad Society as well as KSOGA for providing me this podium. My topic today would be on progestogen. Which one, in whom, who are the ideal candidates, when to start and which route to follow. So the outline of my talk would be pregnancy, usage of progestogen in preterm births, in preventing preterm births, miscarriages, infertility, both in luteal phase supports, in IVF fresh and frozen cycles, and what does the evidence tells us to follow. So different formulations, we are aware, IM preparation of progestogen is still considered as gold standard, but highly painful. Subcutaneous, because of water solubility, makes it less painful and more comfortable. Oral progestrogens, because of reduced particle size, it becomes more compliant when it comes to patient-friendly approach. Dydrogesterone, on the other hand, has a good bioavailability score. Strong receptor affinity, well tolerated, but things to be kept in mind is liver first pass metabolism. Vaginal route, higher concentration of the drug is achieved in the uterine tissue. Effective transformation of the endometrium into secretory phases, well studied in vaginal preparations. Now, prophylaxis for preterm birth, we know that progesterone inhibits myometrial contractions, also has an immunomodulatory effect on the converting from TH1 type to TH2, that is anti-inflammatory state during pregnancy. Now, types of progesterone in various RCTs and meta-analysis studied in preterm birth are natural, either vaginal or pessaries, gel or pessaries, oral dydrogesterone, and synthetic, that is OHP17 as an IM route. So there was an era where in 2015 we started using rampantly of 17 OHP preparations. This was the only class of medicines which was having a demonstrable and significant reduction repeatedly and helpful in preventing the recurrent pregnancy, recurrent preterm births. But again, a review article in 2020 also suggested same thing, that is women between 20 and 36 weeks of gestational age, 17 OHP, 250 milligrams IM weekly starting from 16 to 20 weeks can be continued till 30 weeks. But the former organizations, that is NICE and FIGO in this part, they also endorsed usage of vaginal progesterone for women with shorter cervix as well, with less than 2.5 centimeter. Now there comes EPIC meta-analysis trial in 2021. They stated that vaginal progesterone and 17-OHPC both were effective in reducing preterm birth before 34 weeks. But absolutely in multifetal pregnancies, there were no clear-cut benefit in unselected twins or triplets, either vaginal or 17-OHPs. However, there was no clear evidence that vaginal was superior to the other. Again, in 2021, FIGO good practice recommendations suggested that women who are considered as high risk of preterm birth should be offered a daily vaginal progesterone or weekly 17 OHP. However, it was clearly not indicated in preventing preterm birth in asymptomatic women or no high risk at all. Whereas in unselected multiple pregnancies, again, the prevention was unclear with the usage of these drugs. Then updated clinical practice guidelines advisory committee 2023, they decided to suddenly withdraw the usage of 17 OHPs from the market, mainly because of the concerns from the cancers, various studies putting forth in the form of cancers. However, the recommendations which were used were vaginal progesterone may be considered as a treatment option for patient with prior preterm birth, singleton, or with a shortened cervix. However, it was not clinically very effective in the absence of short cervix. Clearly, it stated that IM progesterone, that is IM 17 OHP, is not recommended for prevention of primary preterm birth. However,
What happened, Nishita?
Nishita?
I think she lost the connection.
Yeah.
Nishita, take off your video. Then maybe you will be able
Nishita?
to.
I think it's
Stop playing
completely
video,
frozen.
ma.
Try calling her, Srimati.
Yes, ma'am.
You have a number?
Yes, ma'am. Yes, ma'am. I've passed the timer, so we'll call her.
Yeah, I know.
Madam, weather is bad. That's it.
Some issues, she's relogging in. Ma'am, while we are waiting for her, there is a question here. Aspirin in thrombocytopenia cases.
We have to stop.
Hello.
Aparna, would you like to answer that question? Aparna?
Yes, I'm here. So basically, aspirin affects the of platelets. So it generally doesn't affect the platelet count. So if it is indicated, you can give, but yes, I mean, if suppose that there is an aspirin, it can also sometimes cause thrombocytopenia. So generally it is avoided. So normally we do not think that aspirin is going to cause thrombocytopenia as it affects the function of the platelet. But generally, if there is a patient of thrombocytopenia, definitely we would not give her aspirin. It's not a very common side effect, but it can be seen. But what is the question here? I don't understand. If there is thrombocytopenia, why would you want to give aspirin? That's something that
No,
we
can we give aspirin?
Aparna, we have
Can we give
situations.
aspirin in thrombocytopenia?
No, I'll tell you. There are situations where patient will be an aspirin like Apla syndrome. We have gone through these cases. Once you start aspirin, even in Apla, we start even before conception and then we'll continue it, no? When they develop thrombocytopenia because of Apla. We had some cases like this. At that time, it's very crucial if you stop, if there is heparin also with that, you stop safely aspirin. Even when aspirin and heparin are there, heparin is there and she bleeds in the first trimester, we stop aspirin, continue with heparin, the pregnancy continues. If it's only aspirin and Apla, you are not giving heparin, that's the latest guidelines in after certain gestation, then we have a problem to stop. But the thrombocytopenia, as you said, Aparna, I think we have to stop aspirin. For some time, temporarily we stop.
With the hematologist, ma'am.
Yeah, temporarily we stop and then we restart it. I have restarted it and the patient continues.
Also, when there is severe, like less than 50,000, it becomes more important. So I think that's also
Exactly.
When it is dropping less than 1,000,
Less than
1 lakh, we just take it and then we are very cautious and we stop. We go up to 50, we may not go. I mean, in a clinical practice, what we are doing it.
So less than 50,000, we should stop.
Yeah, that is mandatory. But you have to be cautious when it comes down to 1 lakh itself.
Has she come, has she joined Srimati Nishita?
Remember, she doesn't seem to be, her name is not there, Dr. Nishita.
See her.
Can we start the next one?
Okay.
And then
Yeah, I think so. We'll start next.
Third one.
And then we'll wait for her.
Do that, ma'am.
No, we won't wait for her. We'll start the third one.
Dr. Renuka, are you there, ma? Dr. Renuka, can you start? And anyway,
Yes, ma'am.
We have had about 4 minutes, ma'am. So we can then restart from that 4th minute from that slide.
Yeah.
Yeah, you can start, Dr. Renuka.
Yes. Good evening, everyone. Myself, Dr. Renuka. I'm consultant Ops Gynae from Haveri Society. Ma'am, are my slides visible?
Yes,
ma'am. Slides are visible.
Second, go to the next slide, Renuka.
So my topic for today is regarding folic acid, like which one to choose, when to start, and for how long it has to be continued. So before we get into the drug, so at least we should know that there are 4 generations of folic acid, which is a dietary form, that is the folic acid, and the second generation would be dihydrofolate, third will be tetrahydrofolate, and the most active form is 5-methyl tetrahydrofolate. So the drugs which are commonly available, the compounds for us when we prescribe folic acid are folic acid, folinic acid, and L5-methyl tetrahydrofolate. So now we have to choose which is best among these, so which will give us the more benefits. So to understand which is best among this, let's dig into the mechanism of action, how folic acid is absorbed in our body. So when we take the dietary folic acid, it has to undergo first 2 steps. That is in the presence of NADP and then in the presence of dihydrofolate reductase, where it has to undergo reduction and then it has to be formed into tetrahydrofolate, which again enters the folate ring, and then it is converted into the 5-methyl tetrahydrofolate, which is an active form of folic acid, which is again combined with homocysteine in the formation of methionine. All this we need to understand because this is the basis for DNA synthesis and purine synthesis. And methionine is one of the important byproduct which we will get only when we have active form of folic acid, that is the 5-methyl tetrahydrofolate. But here what are the blockages? What we get is, first is conversion of folic acid to tetrahydrofolate. That is usually a 2-step process and it is dependent on NADP and the dihydrofolate reductase enzyme. So if these two are not working properly, so the entry itself is hampered. So thereby it cannot enter the folate cycle, and that leads to something called as unmetabolized folic acid accumulation. That is the first thing. And second problem what we can face here is, even if there is an active form of 5-methyl tetrahydrofolate, it cannot enter into this 1-carbon cycle sometimes because there will be a deficit in vitamin B12. So that cofactor is very much essential. Even if there is active form of folic acid, we need the cofactor vitamin B12 for it to enter in this one carbon cycle, so that can lead to DNA synthesis and purine synthesis. And one more, recently what we are seeing is if there are some genetic mutations in the MTHFR gene, in that scenario also, even when we give the normal folic acid, the body cannot absorb it. Again, that will be leading to accumulation of unmetabolized folic acid. So by this, we can understand that there are two components which we have. That is, one is folic acid, that is the dietary source or the one which we supplement, and one more is the active form. Okay. Pros with folic acid supplement, it is more cost effective, it is heat stable, and it is very much available. But again, its effects on, if whether it is effective against neural tube defects, the results are not completely there, because there is a drawback of this unmetabolized folic acid. So how much ever we are giving, whether the body is able to absorb it. So the drawbacks of this folic acid, the risk of unmetabolized folic acid buildup is more. And when we go for the active form, in that also, that is more effective if we have the B12 availability, because both of these will work well only when we have B12, because B12 acts as a cofactor for us. So this will help us in reduction of the preeclampsia and gestational hypertension risk. But the studies are very limited, and it is also expensive compared to the regular folic acid. So when we go for a population based, it becomes little more expensive. So what I would like to tell here is, among these two, it depends on the case to case basis. And before we jump to the conclusion, I would like to tell, let's go for an CBC and a peripheral smear, just to see whether the patient is anemic, and if she is anemic, whether she is megaloblastic anemia, so that if we want to supplement her with folic acid, we have to also supplement her with B12, so that she can get the maximum benefits out of it. So next, coming to the folic acid, like when to start. Okay, according to the WHO guidelines, they tell that the pregnant woman should start from the time they begin to conceive. But they have not mentioned exactly from when, whether it is 3 months, 4 months, or 6 months, they have not mentioned. But she has to continue till 12 weeks of gestation. And one more thing, what they have put up in the WHO guidelines is, to prevent the neural tube defects, the woman should aim for a red blood cell folate concentration of at least 906 nanomoles per liter. Okay. The thing is, to achieve this concentration, with reference to this article I'm quoting, like with 4 mg of folic acid daily, it may take around 20 weeks to reach that RBC cell folate levels, that is between 1000 to 1340, which is optimal for reduction of the neural tube defect. So if we go by this data, that the concentration which is needed to reduce the neural tube defects, then we have to start the folic acid at least 5 to 6 months prior to the conception. And next is how long to continue it. And according to guidelines, again, they have told like at least until for the 12 weeks of gestation. And one more, according to the RDA of the pregnant woman, according to WHO, it is again recommended to continue it during the pregnancy to prevent the maternal anemia, puerperal sepsis, low birth weight, and the preterm birth. And even during the breastfeeding women also, it is recommended to take 500 microgram. So from this, we can tell that from preconceptional till the lactational period, the folic acid is essential. So coming to my conclusion, what I would like to tell is, folic acid, we can use it in the like primary cases where there are no risk factor and there are no history of recurrent abortions or any autoimmune diseases, example like rheumatoid arthritis, or if she is not on any drugs like methotrexate, because that is one thing which will block the first step for conversion of folic acid to tetrahydrofolate. So in those scenarios, we can go for folinic acid. And if there are cases of there is a previous history of neural tube defects, or there is a case of recurrent pregnancy loss or preeclampsia, in them the preferred choice will be 5-methyl tetrahydrofolate. And when to start, it will be ideal to start 5 to 6 months prior to conception. And how long to continue? It is like from preconceptional period till lactational 6 months of the lactational period, we have to continue it. But one thing before I conclude, want to tell is regarding the unmetabolized folic acid, because there are no studies which have come up which have told what are the effects of unmetabolized folic acid for the mother as far as the fetus also. Thank you.
Actually, you finished quite early. That was a good presentation, very precise. Though
Thank you.
some of the conclusions may not be accepted by all. Dr. Aparna, would you like to ask the question, please?
Yeah, so I think good presentation. Two things. One is that have you heard about the recent recommendations from the ICMR on multi-micronutrients in pregnancy? Have you read about it? I mean, there's a recent paper because now we are talking about not just iron folate supplementation, but we are talking about the multi-micronutrient supplementation.
Yes, ma'am.
So there is a recommendation from ICMR which says that you should have it's called an India specific MMS supplement.
Okay.
So so generally the dose is 500 microgram of folic acid. But what is the logic for that? And also my second question would be that, are you aware of any side effects of folic acid, like too much folic acid? Have you heard about that?
No, ma'am, that I'm not aware.
No, because it's an important part. See, most of the time, as we are all aware, that we are giving excessive folic acid to people, right? And sometimes for the lack of folic acid, which is coming in a dose of 400 microgram or 500 microgram, everybody is giving a 5 milligram tablet. Would you agree with me? So do you think that there is a problem with that? And if yes, I mean, and in fact, L-methyl folate comes in a dose of 1 milligram.
Yes, ma'am.
So that's one reason why it can, at least you can give a smaller dose, because folate, and if you look at the anemia prevalence also, and if you look at the profile of women who are anemic, the folate levels are always more than 20. So it's not the folate deficiency which is actually too much, because we are giving in too much folate. So it has been associated with autism also. So somewhere we are faulting on too much folate in those terms at all. Like maybe of course NTD is one part of it, but too much folate is also a difficult part in terms of side effects.
Okay.
Sundari?
Yeah.
Would you like
See,
to?
you said that the recommendation of the folic acid, is it universal recommendation for 6 months prior to conception, or it is specifically in women who are found to have the folic acid deficiency?
Ma'am, they told like in case if you want to prevent the neural tube defect, to achieve that optimal level, we require at least 6 months if we supplement her with that much amount of folic acid.
No, see, because folic acid, how much you need? What is the amount of folic acid you have in the body? Total folic acid if you take, and it is 2 to 3 milligram, that's all. So that you get through your natural foods most of the time. Deficiency of folic acid is not very common, number one. If at all it happens after the late trimester of pregnancy, number two. Number three, if your patient had the neural tube defects in previous pregnancy and all, such people, yes, we agree, you have to supplement them quite early, you have to start. As Dr. Aparna was telling now, the greatest concern is the folic acid, excess folic acid. Same WHO says if the folic acid is more than 1000 micrograms per day, it can lead to a lot of toxicity and complications. So we have to balance that. Only people who had that definite folic acid deficiency, yes, we may have to supplement 3 months early, we start supplementing them. But otherwise, every patient you start preconceptional folic acid. I think that we have to be balancing that. And any other problems? Autism, she said, any other problems with the excess folic acid?
Cognitive behavior, that's what I had read, ma'am.
Yes.
And it is leading to accumulation in the cord blood, the unmetabolized folic acid accumulation, which is leading to the hemorrhages, brain hemorrhages in the children, ma'am. That's what I had read.
Even otherwise, there's a lot of things they talk about: slow brain development, cognitive developments, okay, behavioral changes, FGR. Okay, there are a lot of things have been spoken. There are a lot of papers on that. So we have to be balancing when we give folic acid.
Yes, ma'am.
Thank you. It was a good presentation, very sweet and short.
Very
good.
Okay, I would like to ask you, dear, about MTH polymorphisms in MTHFR. Do you think it makes a difference? Do you think we need to give only 5-methyl tetrahydrofolate, or by just giving folic acid, we can easily avoid the polymorphisms? What do you think?
Only in cases where there are previous history of neural tube defects or recurrent pregnancy losses, I would like to go with 5-methyl tetrahydrofolate, ma'am, thinking there might be some issue in spite of giving a good amount of folic acid in the previous pregnancy, there were neural tube defects. Otherwise, if a primary woman comes to me, then I would like to go with folic acid, because polymorphisms in Indian scenarios, again, as per the data, in North India, it is around 37 to 40%. So we do not have much. It is not even cost effective test for each of the individuals now.
Yeah, the thing is, giving folic acid itself should not make a difference, because there are studies now which tell you that giving 400 micrograms of folic acid, I'm not talking of 5-methyl tetrahydrofolate, just giving 400 micrograms of folic acid, they have found that it does not make a difference. Polymorphism does not affect the absorption of folic acid at all. So right now, and then again, one more very important thing is that there are no studies which tell us that 5-methyl tetrahydrofolate can prevent NTDs. There are no studies. And since everything is based on evidence, we still have to wait till we get the evidence that 5-methyl tetrahydrofolate can prevent NTDs. But we have so many meta-analysis that about folic acid preventing NTDs. So we have to wait till we get the final word before we pronounce that 5-methyl tetrahydrofolate should replace folic acid. Okay?
Yes.
Ma'am, there has also been noted to have unmetabolized folic acid risk of cancer.
Yes.
Yes. Yes.
Cancers there.
Yes.
Ma'am, here that is what I wanted to ask as well, a practical tip, ma'am. What will be the consensus? Because as you rightly said, if there is a past history of neural tube defect, we do not have evidence to say we can give the 3rd generation or the 4th generation folic acid. We have to give only FOL5. But we know that MTHFR mutations are common in India. So how do we bridge the gap? So should we then give them FOL5 as well as 3rd generation folic acid?
No, I think Srimati, what we need to do is we have to tell all the drug controller that we should stop having 5 milligrams of folic acid in all our iron preparations. Not only iron, even calcium preparation come with all these three. So, and people are not bothered. They just prescribe a calcium preparation. See, they give folic acid along with B6 and B12 as a supplement throughout pregnancy. They give iron along with these three. They give calcium along with these three. We are loading our patients.
Yeah, that should be stopped.
We should tell the drug controller that we need to look into this. Aparna, you all should do something from AIMS.
Ma'am, so I would like to clarify here that most of the folic acid preparations that come in combination with iron are in a dose of 500 microgram.
Micrograms, not
Yeah,
yes.
that is what even I thought.
Yeah,
most of it is 500 microgram.
But the individual folic acid, which is 5 mg,
that is 5 milligram.
A preconceptional folic acid that you're giving is not in combination with iron. So that's a higher dose. But there are certain states, and in fact, I must tell you that Karnataka is one of the states where there is availability of 500 microgram of folic acid tablet. This was brought to our notice by the state official of Karnataka in a very recent meeting of the ministry officials in Delhi, and he actually showed us the packet also. So you must look for it, and you must prescribe and tell your patients to take the adequate dose of folic acid and not take unnecessarily a high dose of folic acid.
Exactly.
And what do we do for women with previous NTD, ma'am?
We have to give 5 milligram.
You should give 5 milligram. There is
5 milligram we have to give. 5 milligram.
No,
yeah, but it is not available. So we end up in giving 5 mg only. Right now we have to do that. But then, yes, we can put in our feedback that this is an extra dosage. See, there is something known as a therapeutic safety. So we have to check how much is the therapeutic safety margin of this dosage and how many years of use this product has seen. So this dosage has now seen, several decades of use and has not resulted in any, any more adverse or anomalies or anything.
How do you know? How do you know?
We'll stop, ma'am. We'll go to the next one, ma'am.
Registry for all that. We don't have
time.
Yes, ma'am. We will stop and we'll go to the next one. I'm sorry. Dr. Nishta, are you ready? Dr. Nishta?
Yes, ma'am.
Yeah. We have 4 minutes left from previous one. If you're ready, you can. Otherwise, you'll go to the next one.
So, how many more speakers, Srimati?
Ma'am, one more, ma'am. And then Dr. Nishta hasn't also finished. So that's why I had to cut short. Because we are actually running short.
ಸ್ವಲ್ಪ ಇವತ್ತು late ಆಯ್ತಲ್ಲ?
No, we started on time.
Yeah, we started on time.
Had a problem with connection.
Yeah. We can go to that slide, Dr. Nishta. That particular slide have already been 4 minutes. So you will have
I think
the rest of the time.
Where she started, let us start the slide, no?
Yeah, yes, ma'am.
Where she left.
Go on, please.
Yeah.
The two former organizations here endorsed the usage of vaginal progestogen with women in short cervix as well. There was clearly no evidence of one being superior or the other. However, in 2021, what we could see that FIGO came up with certain other guidelines wherein they offered both vaginal as well as OHP 70. And here, I think this slide also I finished, ma'am. And then comes the cohort. It was a small retrospective study. They also failed to identify any beneficial effect of 17 OHP in prevention of spontaneous recurrent preterm births. However, on the usage of vaginal, the consensus were very clear regarding the usage of the total dosage of usage in patients with vaginal progestogen. The dosage was never exceeding more than 200 milligram per day. There comes the recent update, that is clinical guidance on the usage of progestogen preparations for preventing preterm birth. This I have taken from April 2025, the latest one. Clearly, they do not support any usage of 17 OHP further. However, vaginal will be proven only in case of shorter cervical length. There comes this newest era wherein 17 OHP suddenly becomes withdrawn from the European market because of possible safety concerns. However, the Indian perspective, 62 relevant articles were published in this study wherein 17 OHP compared with that of placebo was sufficiently enough to have an evidence compared to that of no placebo at all. It has somewhat reduced the recurrence of preterm births. However, more studies were needed. Patki et al. In 2024, he stated that expert opinion committee in preventing preterm birth, the Indian guidelines dydrogestrogel at the dosage of 10 milligram thrice a day, 400 or 200 vaginal or SR can be used up till 20 weeks in typical cases. However, Indians still support the usage of 17 OHP once a week for 36 weeks onwards. Up till 36 weeks. Now, progestogen in recurrent miscarriages, theoretically, we know it has proven beneficial effect on endometrial blood flow improvisation and immunomodulatory effect. There comes 2015 and 2020 Promise and Prism trial respectively, wherein the usage of vaginal preparations 400 in recurrent as well as vaginal versus placebo in case of early pregnancy or threatened, they did not have any significant increase in reduction in live birth rate after 24 weeks of gestation. However, in PRISM trial, there were a small subgroup with history of previous recurrent miscarriages. They were highly beneficial with the usage of vaginal. However, both of these studies did not support the role of progestogen in LPS as well. 2020 guidelines, it was clearly benefited. The usage of vaginal progestogen was at the dosage of 400 milligram twice daily was helpful in preventing miscarriages with threatened miscarriages. This is on meta-analysis 2024. The 15 RCTs were concluding, saying that in women with early increased recurrent pregnancy loss, progestogen will be probably a lifesaver, increasing live birth rate without adversely affecting maternal and neonatal outcome. However, the Indian perspectives, this is again in 2024, oral versus vaginal, oral was beneficial over the vaginal one. 40 milligrams is what the administered dosage in the event of vaginal bleeding, tapered over to 10 milligrams BD over a period of 16 to 20 weeks. Current evidence, however, does not support the usage of HCG in threatened miscarriages. RPL, the dosage is same, 10 milligrams can be continued BD up till 16 to 20 weeks. However, in case of recurrent preterm births can be considered up till 34-36 weeks. The dosage includes extension period of 18 to 20 weeks in case of multiple pregnancies as well. How about progestogen in ART? Luteal phase support, what does the evidence say? The diagnosis and treatment of luteal phase deficiency, a committee opinion in fertility study 2021 stated that in spite of so much of research in LPD, there is no currently reliable methods to diagnose a case of luteal phase deficiency, because of which the treatment is almost empirical. Most common methods include various serum progestogen levels, but none have been proven so far very effective. So should we know the ideal causes of LPD in the background? Yes, hypothalamic amenorrhea, PCOS, obesity, stress, thyroid dysfunctions, and ART as well can be the sole cause for luteal phase deficiencies. So, however, the proposed treatment says that ideally correct the underlying cause for LPD rather than going and treating it. And empirical strategies which have put forth is serum luteal progestogen, supplemental luteal progestogen or P4 plus E2, as well as HCG in only GnRH driven cases, as well as in anovulatory cycles when it comes to ovarian stimulation protocols. Clear-cut evidence that no progestogen supplementation is beneficial for treating LPD. When it comes to meta-analysis studying the luteal phase support in ovarian stimulations and intrauterine IUIs, that is intrauterine inseminations, no consensus supporting the usage of progestogen alone in OS cycles or IUI cycles. Clearly beneficial only when they are used with subsequent gonadotrophin stimulated cycles. What does IVF says? IVF recommends, ESHRE recommends progestogen is mandatory for luteal phase support. It's a strong evidence because we know that lots of supraphysiological levels are hampering the endometrial receptivity. So when we are planning for a fresh embryo transfer cycles, start the progestogen on the day of egg retrieval. HRT cycle after adequate preparation of endometrium in between day 12 to day 14, at least ultrasound monitoring of 8 mm triple line pattern. Whereas in TNC as well as modified natural cycles, we wait for LS surge and HCG to follow the start of progestogen, that is 36 hours later. What about the progestogen usage for LPS in case of IVF stimulations? We have evolved from the starting usage of natural progestogens, highly painful, from 50 milligrams OD till recent dates to only 400 milligrams vaginal pessary. Luteal phase support should be administered until the day of pregnancy test is what is consensus tells us. When it comes to various routes and formulations, they have compared n number of studies, oral versus IM, various vaginal preparations, oral versus gel versus subcutaneous, everything. However, for RCTs 2022, evidence was heterogeneous on the optimal route of administration of progestogen for LPS in FET cycles in IVF. When we consider alone dydrogestogen support in case of LPS, it was clinically proven that alone dydrogestogen support will lower the clinical pregnancy rate. Hence, it is always best to combine with vaginal or subcutaneous routes. Then comes vaginal versus IM routes. There was no difference in between implantation, miscarriage, and live birth rates in clinical randomized controlled trials. However, the usage on recommendations of progestogen in fresh ET is when we are planning oral dydrogestogen 10 milligram TDS as well as vaginal 200 milligram to continue up till 20 weeks. Natural or modified cycles, options include vaginal as well as oral. Either gel can be also used in them. And when it comes to FET cycle, a proper vaginal 400 milligram twice daily and oral supposedly 20 milligrams. Whenever we find that serum progestogen level is low, only then there comes a role of IM substitution or subcutaneous water-soluble substitution. However, the current clinical practice in luteal phase support, only clear-cut indication of low-dose HCG in luteal phase support is given in patients with GnRH triggering fresh embryo transfer cycles. And choosing an LPH, dydrogestogen superiors the other preparations as well when it comes to patient satisfaction as well. And should be started on the day of oocyte retrieval and after thorough endometrial preparation. Should be continued until a positive pregnancy test is confirmed. However, many clinicians still point towards a luteoplacental shift is completed, that is up till 10th to 12th week of gestation. So what should be the ideal route and dosage of administration? Oral route has been clinically proven to have better patient compliance. Appears to be the first choice when it comes to luteal phase support. Combination of dydrogest and with micronized vaginal progestogen is ideal combination. And here comes just a week back update in the usage of progestogen. This is the latest guideline. This is the latest study published just 1 week back. Sublingual progestogen lozenges should be serving as a viable alternative to IM preparations in FET cycles. So how about the safety concern after learning so many things of dydrogestogen and various progestogen? This is again in 2025 January issue Human Reproduction asks a question in this study. Is there any association between dydrogestogen exposure during early pregnancy and reporting the birth defects? Yes, the question says, the answer says yes, there is a small incidence of hypospadiasis and congenital heart defects. However, it needs to be promised in future studies. So key points to take away is it is essential to have progestogen to maintain and as well as initiation of pregnancy. Extensive research so far still highlights the gap between the science and practice. Despite extensive research, the quality of evidence for luteal support is very less. That asks us to have more research-oriented studies.
Time's up, ma. Time's up. Can you summarize?
Yes, ma'am. LPD treat the underlying cause. IUI cycles with gonadotrophin needs LPS. There is a definitive role in preventing preterm birth. Progestogen has a promising role in threatened miscarriages, is a must in IVF cycles. Now all eyes remain on sublingual preparations. Thank you. These are my references.
Very much referenced talk, Nishita.
Thank you.
Sundari, would you like to ask?
Okay, you said extensively about the luteal phase deficiency. A patient comes with a threatened abortion. Okay.
Yes, ma'am.
How do you go about it as far as the progestogen is concerned? She just had a spotting. She's about 8 weeks of pregnancy. What do you do?
Yes, ma'am. I would go back and check whether it was a spontaneous conception or any other ART was used.
It's spontaneous.
Yes.
ART, you said you are loading them with them until at least 12th week. So there's no question of asking a progestogen, is it not?
Yes, ma'am.
Yeah, this is a spontaneous conception. She comes with the spotting to you and she's about 7.4 weeks. Yeah.
Yes, ma'am. I would definitely do a transvaginal scan, look for the corpus luteum. Corpus luteum gives us an idea whether it is well formed or inadequately prepared on ultrasound. Then go ahead with support with the vaginal progestogen start and oral progestogen as well.
When is it indicated actually, progestogen in a threatened abortion?
At the time of threatened bleeding, on the onset of acute bleeding.
It's when there is evidence of subchorionic hemorrhage.
Yes.
Otherwise, if she just comes with a spotting, you can wait and see. If, as you said, if the corpus luteum is strong and you think that it's okay, you don't need to that too. You say vaginal plus oral you want to give. Why so much of progestogen you want to give? In IVF cycles, I'm not questioning because I'm not an expert in that also. I see all of them loading them, okay, with all possible progestogens. But I'm asking about the spontaneous cycle. See, the recommendation is only when there is a subchorionic hemorrhage.
Yes.
What is pregnant trial?
It's Sundari.
You said,
You'll have to ask Aparna. Aparna?
Yeah, Aparna, please. Yeah.
Please. Because she has overstepped her time limit, so there are only 2 minutes for questions.
Yeah. Sure.
So,
sorry.
Good presentation. I just want to know that, we have to be somewhere emphatic about the evidence which is there. And if there is something which is there in the evidence regarding, it is about 17-OHP.
Yes, ma'am.
Which you have not talked about. So what is that thing which came and the current status of 17-OHP in the prevention of preterm labor? If you have to say yes or no, will you give, will you not give?
Ma'am, no, I'm not supposedly totally driven towards 17 OHPs. Still, I would consider usage of vaginal as well as oral preparations only.
No, I'm just asking 17 OHP, yes or no?
No, ma'am. Still, we have to have Indian guidelines, but still no.
No. There is no doubt about it. Let us understand where there is evidence, right?
No,
so
ma'am.
17 OHP is one drug where the FDA approval was given and then the
withdrawn.
Yes.
So I think we have to put our foot down to say that we are not giving 17 OHP, right? And this is actually based on the prolonged trial, which I don't think you mentioned. It's important.
Yes.
Right? So the MICE said yes, the prolonged said no. Then, of course, there is SMFM guideline and then the FDA approval, which was withdrawn. So there are certain things in progesterone which is watertight and that needs to be coming out.
Next one, ma'am, we'll stop.
Time is over. Fine. No, I wanted to ask her the same question, current status. But in India, everybody continues to use it.
Stop sharing by ma'am's.
And by FDA. Okay,
stop
so
sharing, Dr. Nishita.
we should slowly.
We have stopped using ma'am completely. We don't use 17.
Yeah, we don't use.
Very good.
Yeah, Dr. Jayashree, meanwhile, can you start sharing your slides while we are discussing? Dr. Jayashree?
Yes, ma'am.
Yeah. You can start, ma'am. Slideshow and you can start.
Yeah.
So good evening, everyone. I'm Dr. Jayashree. My topic is antenatal corticosteroids in pregnancy is a boon or bait. Am I audible, ma'am?
You're audible, but it's not a slideshow. Can you put a slideshow and move your slides?
I think it's slideshow only.
This slide, no. Adu, the slides are not seen. Last time also she did it like that only. It becomes.
Move down the slides, Dr. Jayashree. Move down.
Yes, ma'am, I have reading.
Okay, continue.
Continue, ma. Slideshow.
Yes, come.
Continue, Jayashree.
Okay.
Your slide is not moving, Dr.
See, go to the
Jayashree.
next slide. We want to see whether it's moving. Go to the next slide from the title slide.
It's not moving.
Okay.
In my screen, it is moving, ma'am.
Stop
No,
sharing
here
and
it's not
restart.
moving,
No,
ma'am.
stop sharing
Okay.
and restart again. Yeah, again start sharing, please. Okay, go down to the next slide.
Fine.
It's not moving, ma'am. 1 second.
Moving.
No, ma'am, it's not moving.
No, it's not moving.
You want me to share for you?
Yes, ma'am. 1 second, ma'am.
Mute everybody, Arun.
Yes, I'm muted, ma'am. I'm muted.
Because
Yeah, I'm muted. Do you want me to share it for you, Dr. Jayashree?
1 second, I am trying.
Yeah, put it again. Yeah, move to the next slide. If slideshow is not working, just move to the slides.
Father, just continue now.
Yeah, just
Yes,
move
ma'am.
the.
Okay. No, ma'am. Hello.
It's not going?
It's not
It's
moving.
going, ma'am. It's going. It's moving.
No,
Not for us. Not
not-
for us.
I think Srimati, you'll have to
Yes, ma'am. Yes,
see, let Dr. Srimati share. Okay.
yes, ma'am. Yes,
To
ma'am.
move
Is that
share.
okay? Yeah, you
Yes, ma'am.
stop sharing, ma.
You stop sharing.
Stop sharing.
Dr. Jayashree.
Yeah, thank you. Perfect. Yeah, you want to start?
Yes, ma'am. Good evening, everyone, ma'am. I am Dr. Jayashree. Am I audible, ma'am, now?
Yeah. Go ahead.
It's fine. Go ahead.
My topic is antenatal corticosteroids in pregnancy is a boon or a bane. Next slide.
Srimati. Okay.
So, American College of Obstetrician and Gynecology suggests and recommends a single course of corticosteroid for the pregnant woman between 24 weeks to 33 weeks plus 6 days who are at a risk of preterm delivery within 7 days, including for those with a rupture membrane and multiple gestation. It also may be considered for a pregnant woman starting at 23 weeks of gestation who are at a risk of preterm delivery within 7 days, based on family decision regarding resuscitation, irrespective of membrane rupture status and regardless of the fetal number. So these are the various recommendations from various society. I will simplify this. During peri-viable period, that is 23 weeks to 23 weeks plus 6 days, both ACOG and RCOG consider for a woman who are at a risk of preterm delivery within 7 days, based on family decision regarding the resuscitation and irrespective of the membrane rupture status and regardless of the fetal number. And New Zealand also consider this administration during peri-viable period, but Government of India, it doesn't recommend. And Cochrane study shows there is no benefit in a steroid and non-steroid group in terms of mortality and morbidity when antenatal corticosteroids are given during 23 weeks to 23 weeks plus 6 days of gestation age. So the clinical benefits, it will reduce the neonatal death by 31%, RDS by 34%, intraventricular hemorrhage by 45%, NEC by 55%, NICU admission by 20%, and early systemic infection by 50%. So clinical benefits, it's adopted from Cochrane database review 2017. Both steroid and non-steroid group has similar mean birth weight, and impact on chronic lung disease was inconclusive. Steroid group had less need of respiratory support, oxygen supplementation, and surfactant. The long-term follow-up data into the childhood showed less risk of developmental delay at 3 years of age, and similar result for childhood weight, height, head circumference, blood pressure, lung function, hearing impairment, and behavioral and learning difficulties. So safety surrounding the use of ACS. For maternal safety, there is no increased risk of maternal death, chorioamnitis, or endometriosis. Safe in severe preeclampsia, small risk for increase in blood glucose level. So we should monitor the blood glucose level, and transient leukocytosis can occur. For fetal, transient decrease in variability of FHR and transient low PPP score for fetal breathing and body movements. But there is a transient improvement in umbilical artery and diastolic flow. So what drug and what dose should be used? Dexa versus betamethasone. The Cochrane review shows there is no difference but limited data. The Government of India NHM 2014, it recommends a single course of injection dexamethasone, that is 6 milligram in a divided doses, 4 doses at 12 hours apart. However, there is a significant decrease in the rate of IVH in dexamethasone group. So non-availability of the acetate group of betamethasone in India will use the dexamethasone intramuscularly. So what is the accelerated dose? So the antenatal corticosteroids with the doses intervals shorter than those outlined previously. That is giving betamethasone at 12 hours apart from instead of 24 hours apart. So RCT by the Kenwell 2012 reported that there is no impact on incidence of RDS if it is given accelerated dosing. So PPRM with steroids, single course of ACS as in the preterm labor, but repeat dose is controversial. Docalus is controversial in PPRM. Antibiotics can be used. According to RCOG, we can use erythromycin for 10 days, ACOG, erythromycin or azithromycin with amoxicillin or ampicillin. And it's not recommended after 34 weeks. So current data suggests that antenatal corticosteroids are not associated with the increased risk of maternal or neonatal infections regardless of the gestational age. A single course of corticosteroid is recommended for the pregnant woman between 24 weeks to 33 weeks plus 6 days of gestation. So in case of multiple pregnancy, it can be used same as singleton, but prophylactically it should not be used. So in diabetic cases, transient hyperglycemia can occur 12 hours after the first dose up to 5 days after the last dose. So it can happen in both diabetic as well as non-diabetic pregnant women. So international guidelines recommend the ACE should be administered to the diabetic woman at the same doses and according to the same indication as that of the non-diabetic. So in case of an early term, that is 37 weeks to 38 weeks plus 6 days, there is a significant decrease in NICU admission due to the respiratory morbidity when we use antenatal corticosteroid. But the rate of admission for the non-respiratory morbidity was higher in the steroid group. And it will cause a neonatal hypoglycemia. We should monitor the neonatal blood glucose level. And analysis of school reports suggests that steroid-exposed children were significantly more likely to be in the lower quartile of academic ability. And there is a raised concern regarding the long-term safety effect when we use it in the early term. So guidelines on rescue dose. And we should not use rescue dose routinely. A single rescue course should be considered provided the gestational age criteria is less than 34 weeks and she is an imminent risk of delivery within next 7 days. The time interval since the first dose of ACS is at least 7 days. The risk and benefits are discussed with the family. So recommendation, according to ACOG, it recommends with 36 weeks, 6 days and NICE 35 weeks plus 6 days. ACOG guidelines recommends up to 34 weeks plus 6 days. India, it recommends only up to 34 weeks. That is 33 weeks plus 6 days. So multiple doses of ACS. According to ACOG, not more than 3 courses are recommended, and fetal growth and developmental alteration can happen with the repeated multiple doses. It can reduce the head circumference as well as the fetal weight. The effect on the cerebral myelination, lung growth, and HV axis. There is also increased risk of cerebral palsy. So what evidence says on the repeated dosing? The ACTROT study shows the steroid group. There is a decrease in the RDS in steroid group, and there is a decrease in duration of mechanical ventilation. But also it decreases the weight and head circumference at the birth. And attention disorder was more likely to happen with steroid group. The MAX study shows there is no difference in RDS and mortality. There is a significant reduction in the weight and head circumference and length at the birth in the steroid group. And there is a significant increase in the neurodevelopmental disability. And ACOG 2017 suggests not more than the 2 courses and only up to 34 weeks of gestation. The previous course, if it is completed 14 days back, and where the birth is expected within 7 days. The New Zealand and Australian practice 2015, it recommends less than 32 weeks plus 6 days and previous course completed within 7 days back, where the birth is expected within 7 days. So coming to the gestational age consideration, during peri-viable period, that is less than 24 weeks, definitely there is a decrease in mortality rate, 71% as compared to 58%, but doubt about morbidity. And between 24 weeks to 34 weeks plus 6 days, there is a decrease in respiratory mortality up to 20%, and also decrease rate of RDS, IVH, and NEC. Between 34 weeks to 36 plus 6, there is no benefit for mortality, but definitely there is a reduction in the RDS by 10%, mechanical ventilation by 6%, but it will cause a neonatal hypoglycemia in the 13% cases. At term, we usually not recommend, but mortality has no benefit, but sometimes it will reduce the neonatal admission because of respiratory syndrome or respiratory problems, and also, but it will increase the low academic abilities in the infants on the long-term effect. So same recommendations applies to the women with multifetal gestation, pre-gestation, gestational diabetes, obesity, as well as the growth restricted fetus. So betamethasone versus dexamethasone, it will cause irreversible as well as an irreversible changes in the lung. So it will stimulate the both type 1 and type 2 pneumocystes, and it will stimulate the beta 2 receptors to release the surfactant from the type 2 pneumocystes, and it will increase the lung compliance as well as the lung volume. So it also has a various gene expression like VEGF. It will help in reduction in the intraventricular hemorrhage, and it will cause maturation of the intestinal mucosa in the neonates. So both betamethasone as well as dexamethasone can be used, and dexamethasone is a benefit because for the 3 reasons. It is heat stable, and dexamethasone has a little bit benefit in decreasing the IVH as compared to betamethasone, and dexamethasone is cost effective, and betamethasone acetate is not available in the Indian scenario. So both betamethasone and dexamethasone, it will have most effect. The effect will start maximum from the 48 hours to 7 days. So for this administration, there is no gestational diabetes screening is required. If pre-gestational or gestational diabetes, monitor for the blood glucose levels. If when with the imminent preterm delivery, one rescue course may be considered if woman remains undelivered after 14 days of delivery. So conclusion is corticosteroids in pregnancy is definitely a boon, but in intervention for improving the neonatal outcomes in preterm births. However, it's crucial to weigh the benefits against the potential risk and consider the individual circumstances, including gestational age, maternal health, and the potential for the long-term effects. Thank you all doctors and KSOGA and BKOGs for this opportunity.
Good presentation, Jayashree.
Thank you, ma'am.
Dr. Aparna?
So in your practice, do you give dexamethasone or betamethasone?
In my practice, I use dexamethasone, ma'am. 6 milligram.
Okay, so why not betamethasone?
Usually, actually, betamethasone acetate, it is a little costlier, ma'am, and it's not available in India.
Yeah, so it has to be a combination, right? It is not
Yes.
available in India. That's why we should not use betamethasone, because it has to be a combination of acetate and phosphate, and it's not available in the present form. The only other thing that I want to ask you is that have you had any update on the ALPS follow-up? Because ALPS trial came in 2016. And in 2024, they have followed up those babies further. And now probably we'll have some more evidence that maybe it is not so harmful. So I know the evidence kind of goes back and forth, but we need to be updated on it. So are you aware of ALPS 2024?
Follow-up.
Follow-up. Because whatever you are saying about the school and everything, it is from the ALPS trial of 2016.
Yes.
Right. So there is a more recent update, which is the ALPS 2024. So I think that's something that we have to look forward to and see if what we are thinking is actually as bad. But the systematic review after the ALPS trial also showed that there is some problem. So definitely in your practice, what is the upper limit of giving steroids for you?
I will use for 34 weeks, ma'am. 33 weeks to 6 days.
Yeah. So we are not giving beyond 34 weeks. So I think that is all. We all have to also agree on that fact that nobody really is giving beyond 34 weeks in most of the settings. So I think that's all, yeah.
Nice guideline suggests that if you're doing an elective seizure before 39 completed weeks, you should give, but I don't think we should do it. Okay, I'll ask you, why does WHO not advocate term? The same thing like what NICE advocated, steroids in low-income countries?
Yes, ma'am. In low-income countries, there is a long-term effect studies are not available in low-income countries, and it will cause neonatal hypoglycemia, ma'am.
Apart from hypoglycemia, especially in low-income countries, WHO, anything else you have read about? It also leads to sepsis and increased neonatal mortality. So WHO says that in low-income countries, do not give term. It is not advisable to give antenatal corticosteroids near term. Okay, Sundari?
Yeah, if you have to give in India betamethasone, you are giving Dexa. But if suppose somebody is giving betamethasone, what is the dose schedule you have to give and why?
Betamethasone 12 milligram, 24 hours apart, 2 doses can be given.
No, in India, I'm asking you. You said that acetate is not there, only phosphate is there.
Yes,
so what is the dose schedule for that? See, because it is short acting. It's not like Dexa is short acting. That's why you give 4 doses. Is it not? Same thing, beta, if you are giving in India, whatever salt is available, phosphate, you have to give like Dexa. 4 doses instead of 2 doses, 24 hours apart. 12 hours apart, 4 doses you have to.
But ma'am, study shows that the accelerated dosing is doesn't has any benefit.
No. Because if you are using only the acetate phosphate is not there in India, we use betamethasone. Without knowing, many people, they don't know that they still use betamethasone. But it becomes a short acting for us. If you have acetate phosphate, it is long acting. It is 2 doses only, 24 hours apart. But because we don't have the salt of acetate, if at all we are using, we may have to give. It is not accelerated here because it's very short acting.
Yes.
If you go to steroids, you have long acting, short acting, prolonged acting.
Yes.
There are 3 types of steroids, is it not?
Yes,
so here it becomes a short acting without acetate molecule in that. Okay.
See, the funny thing is we've been giving the betamethasone phosphate for so many years.
Yes.
We woke up.
But if you see the Indian guidelines, okay, health and family welfare guidelines, they advocate only dexamethasone and they give the reason also for that.
Recent, Sundari.
Yeah, it is 2016. 2016.
Before that,
2016.
Before that, they not give only phosphate without knowing that it was.
Yeah, we didn't know that. Yes, I agree.
That's what I meant.
We have given.
Okay.
What are the other benefits you have? We have time or we exceeded the time?
No, ma'am, we've exceeded, ma'am.
Okay, then fine.
Good.
Thank you, ma'am.
All 4 have done a very excellent job.
Good job, yeah. Congratulations, all of you.
Very good.
So we now go to the best part of the webinar. Of course, the first 4 talks were also nice, but it's a cherry
on the cake.
The cherry on the top, ma'am. So
yeah,
we have
don't avoid the cream.
So for our expert talk by Dr. Aparna, whom we had already introduced, Professor in OBG. So we are looking forward to your talk on drug safety in pregnancy. Over to you, Dr. Aparna. Thank you.
Thank you. Thank you, Jyotika ma'am, for having me here today. And thank you, Srimati, for the introduction. First of all, I would like to say that a disclaimer that this topic is a little, offbeat. I'm a maternal fetal medicine specialist. I do a lot of fetal medicine, fetal interventions, but this is something which is a little, but I would also agree by saying that, this is something that is there as a part of practice for everybody. So I will not take much time on it, but I think during the preparation for this topic, I found something which is very interesting, and I think everybody will be, will find it very useful at the end of it. So I'll begin by saying that, we have to consider how do drugs affect pregnancy, how much is it being used, and why is it such a big problem, and what are the factors which actually affect their action, and then pregnancy labeling. I think that's important, old versus new. So all of it started with the thalidomide tragedy, which happened in 50s and 60s, where the anti-anxiety and anti-hypnotic drug, the hypnotic drug was used and it led to severe limb deformities. This was a landmark event which caused the FDA and US drug amendments happened and major drug safety norms came in. So if we look at pregnancy, the pharmacodynamics are very, very important. So we need to understand that plasma volume increases, the cardiac output increases. This leads to lower concentration of some of the drugs. So we might need to increase. So optimization of the dose is also important, as this leads to subtherapeutic drug levels. So say for example, L-Troxin. So we know that 30% straight increase of the drug dosage is important. Also decreased plasma albumin concentration. So there is increased volume of distribution of the drugs which are protein bound. So there is lesser amount which is protein bound. So those drugs get circulated more. At the same time, the body fat is increased. So fat soluble drugs, the volume is increased. So again, the dose will be decreased. So there is subtherapeutic level. And more importantly, progesterone delays gastric emptying. So that leads to delayed onset of drugs. So whatever medication we are taking, the effect will come later. So in terms of the drug transfer, so we also need to be mindful that what are the factors which affect the transfer of drug across the placental barrier. So the protein binding, we know that only the free and unbound drug can cross the placenta. So that's one of the factors. The pH difference. So fetal pH is slightly more acidic than maternal pH. So weak bases can cross more. Again, moderately lipid-soluble drugs can easily diffuse, and molecular weight. So we know that the smaller drugs can diffuse more than the larger. So if it is more than 1,000, they do not cross the placenta. Between 500 to 1,000, they cross the placenta less. And then again, in the third trimester, the transplacental transfer is more than what we normally there. So it is not a small problem. If you look at it, every pregnant woman, so every other pregnant woman is using medication in pregnancy, at least one medication, and on an average 2.6 medications at any point in time in pregnancy. And the first trimester prescription medications, like you see progesterone, it has increased, a lot of aspirin, a lot of preconceptional to first trimester medications have increased. And use of 4 or more medications in the first trimester has increased to up to 1/3 of our pregnant women. So this is actually a big problem. So what are the factors that determine what affects the fetus? What is the factor? So the timing at which, we are taking the drug, what is the dose, what is the nature, and the most sensitive is the first trimester. Development has 3 periods, which is called the all or none period. Then there is the embryonic period and there is the fetal period. The all or the none period is 2 to 4 weeks post LMP, where the exposure either results in loss of the pregnancy effect. So it's like if you have crossed that period, and even if you had taken the medication during that period, you don't have to worry now because that is an all or none period. There is not going to be any residual effect. So if you have taken a drug within 4 weeks of LMP and you have pregnancy still continuing, that's an all or none period. And it is reassuring that, okay, you have crossed that period. And the drugs do not cause malformation because by that time, it's only a mass of dividing stem cells which have not yet differentiated, and they have a minimal contact with maternal circulation. So that's the all or none period. The most critical period is the embryonic period between the 4 and 11 weeks LMP, and it has the greatest likelihood of causing birth defects. The fetal period is 11 weeks post LMP. It does not cause malformation, but it can cause disruption, mainly by several mechanisms like hypoxia, vasoconstriction, hypotension, and causing oligohydramnia. So the most crucial period where the drugs can actually cause malformation is 4 to 11 weeks, following which there can be other mechanisms of damage. So the drugs how can they affect the fetus? They can cause teratogenesis, that is, they can cause malformation by interfering with the fetal development. And we know valproate, warfarin, lithium, and isotretinoin. They can cause adverse pregnancy outcomes by causing miscarriage, fetal growth restriction, or stillbirth. Or they can affect the fetus by causing neurodevelopmental complications. And this is the most dangerous part because we can't even predict it. We can't see it. We cannot see it on ultrasound, like autism, intellectual disability. Again, some of the selective SSRIs, they can cause poor neonatal adaptation syndrome, which is generally mild and self-limiting. Again, there could be some of the benzodiazepines and opioids, which can cause neonatal abstinence syndrome or withdrawal from the opioids. So these are the other ways in which the drugs can affect the fetus. And then, of course, there are certain actions which are related to the pharmacological action of the drug. Say, for example, the ACE inhibitors. They can cause renal impairment in the fetus, which we know that it can cause problems. Azathioprine is an immunosuppressant, so it can cause neonatal bone marrow suppression. Beta blockers can cause bradycardia and apnea. NSAIDs can cause a premature closure of ductus arteriosus, and warfarin can cause thrombocytopenia or fetal hemorrhage by affecting the coagulation. So this was about how the drugs affect, in what ways the drugs can affect. Now, I realize that, there's no end to the way we can think the number of drugs that they are taken in pregnancy and how they affect it. We are typically used to addressing the effect of the medication using the old pregnancy labeling, which is based on the alphabets, right? So the assessment of the drug safety in pregnancy following the thalidomide tragedy was that there were preclinical studies had to include at least 2 different species, of which one had to be primate. But unfortunately, also after the thalidomide tragedy, the FDA excluded women of childbearing potential from early phases of most clinical trials. So there is actually not much of an evidence for most of the drugs in pregnancy. So only a small, if you look at the pregnancy medications, only a small percentage of drugs are actually completely contraindicated in pregnancy. But for majority of the drugs, the labeling should be providing of what is known in a way that enables decision of treatment. So just to say that, there is no evidence is not enough. So how do you actually put it across? So the ideal way is that, do not take any medication. And we do try to say that to all of our patients. Even if there's some fever or something like that, we just say, don't take any much medication, just try local, whatever it is. But that's not always realistic or effective. But what we need to understand is to have an accurate evidence-based knowledge, communication to be clear, education should target all the stakeholders involved in pregnancy. So from there originated this concept of pregnancy lactation labeling rule. And this is PLLR. And I must admit that I have been practicing, I have been advising, but this time I really went into the depth of it and I found that it's actually quite simple. So this started from 1979 and this initiative actually began, but in 2014, for the first time, it became published. So this was the time when our ABCD, and X was disposed of. And since 2015, this PLLR is in the use, and FDA says that you cannot use the ABCD criteria anymore. So what we typically understand is the ABCD criteria, where A shows no risk, B shows that there is no evidence of risk in humans, but animal studies may show some risk. C says that risk cannot be ruled out. Animal studies show risk, but there are no human studies. Now, D shows that there is evidence of human fetal risk, and X is contraindicated in pregnancy. While it is easier to understand the X, rest everything else is confusing. So X is just a few drugs. So rest everything else is confusing. And since 2015, we are not supposed to use this system anymore. But if I just want to see a raise of hands of who is actually not using this system, that will be a reality check for all of us. I think we are so used to using this system that maybe some of us may not be knowing that this is not to be used no longer. Now, the problem with letters is that it is oversimplistic. It is misinterpreted as a grading system. And a drug with adverse information in animals could be labeled as the same category as a drug with no animal information. So essentially, the category C does not differentiate between an adverse information and no information. And that's like, 70% of the drugs are in category C. And we are just giving those category C drugs thinking that, okay, everybody is giving, let me give, it is under category C. But we need to understand that we cannot call a medication category C any longer. So the intent of PLLR is to provide the prescriber with relevant information for critical decision making, also get a more complete statement of the known risks, consideration of medical disease, animal data put in context, and human data added when available, and explicitly states when no data is available. So this is the PLLR rule, which is available, which is to be updated from 2015, and it should include 3 sections on pregnancy, lactation, and females and males of reproductive potential. So every drug that we are giving has to have these 3 sections of pregnancy, lactation, and females. And each of these sections should include a risk summary, clinical consideration, data from studies, dosing, and adverse reaction info. So this actually gives us an individualized risk benefit assessment. And this is the change which has happened. Earlier, the pregnancy, there would be a pregnancy section, then there would be a labor delivery section. But now pregnancy and labor delivery section is included in the pregnancy section. The lactation segment is the second one. And the new is that the females and males of the reproductive potential should be specified. So if there is an infertile couple, or if there is somebody who's like, adolescent, so the effect of the drug and that particular age group should be mentioned by the medication. So this is an example on how a medication, suppose you're giving a medication, it should have description under 4 headings. That is there a pregnancy exposure registry for that medication? Is it available? It is not available. If it is not available or available, what is the risk summary with that drug? What are the clinical consideration and what is the data available? Say, for example, any particular drug that if we are describing, there is a pregnancy exposure registry that monitors pregnancy for in women exposed to any particular drug trade name. Say, for example, so I was doing this search today with albendazole because very recently in my OPD day before yesterday, a staff nurse came to me and asked me, I have been taking, I have cysticercosis and I've been advised to take albendazole and I am lactating. Should I take, should I not take? And I have to take it for twice a day for 2 weeks. So I started looking it up how to do. So then this is how I'm going to say that there is a pregnancy exposure registry that monitors a woman pregnancy outcomes in women exposed to albendazole during pregnancy. And it should include specific contact information. And if there is no registry, we need to mention that there is no exposure registry. And are we ready to register our women or pregnant women into that registry? Because now they're going to take it or they have already taken it. The second part is the risk summary. If the drug does not have any systemic absorption, we need to mention that this particular drug is not absorbed systemically. But if there is a systemic absorption, then we need to indicate that it is which is the risk statement based on human data, animal data, or pharmacology, or a background risk based on general population or a disease population. Clinical considerations, 5 optional subheadings: disease-associated maternal risk, dose adjustment, maternal adverse reaction, neonatal adverse reaction, and labor and delivery. And then pregnancy data. Last point is the pregnancy data, whether human data is available and the animal data available. So essentially what we want to say is that if you have a woman or any patient who's taking any medication in pregnancy, you cannot say this is A, B, C, D category of drug. What you have to say is that you have to write the risk summary and the clinical considerations onto her OPD card or paper or case file and discuss with the patient in an explicit manner that these are the risks, this is the knowledge that we have, and this is the situation very, very openly. And if you want to continue the pregnancy, we all understand, and you can go ahead with this and with the current data which is available. So during pregnancy, we need to see if there is a pregnancy registry, what is the risk summary, what are the clinical consideration, and what is the data which is available. For lactation, we need to see for a risk summary, clinical consideration and data. And for women and male and female in the reproductive group, we need to look for that, do we need a pregnancy testing before taking this drug? Do we need to check if the patient is on any contraception? And we need to check whether it's an infertile couple who's planning for fertility. So these are the things which need to be in consideration before we prescribe a drug. Now we will think that, oh my God, this is so difficult. How are we even going to do this in our day-to-day practice? Well, this is where I'm going to say that no, it is not difficult. So for example, albendazole in pregnancy. So this is the National Library of Medicine, and this is Daily Med, right? So this site is freely available. You open, you will come to this particular site here, and then you write albendazole here. So I wrote albendazole here. You will get a list of albendazoles. When you click on the albendazole tablet, then you will come to this particular window and point number 8, where it says use in specific populations. It will tell you pregnancy, lactation, female and males of reproductive potential. So 8.1, 2, and 3 is something which is important for us. In pregnancy, it is going to give you a risk summary. And the data shows an animal data. There is no human data. So this is what we need to. So on a click of a button, you have everything which is available. But what we need to know is that there is no ABCD. You need to tell us the risk summary and the data which is available, and let the patient decide after having an explicit knowledge about drugs in pregnancy. So this is something that we have to understand. So I also looked up that when it is so difficult, is there evidence on the usage and what is the assessment? So there was this assessment of knowledge of the new PLLR among pharmacists and physicians, and they said that 30% stated that new rule would continue, that despite the new rule, they would continue to use the lettering system. 83% believe that ABCD criteria is a useful resource. And basically, they said that despite significant flaws in the old system, most preferred it. So it's important to enhance the knowledge in this area, and it is crucial for improving risk communication and quality of care. And I, for one, I feel that, it's so easy to access this information. It's definitely not black and white. Like we say, 70% would come under category C drug. And that doesn't say anything. That doesn't give any information on any of the drugs. So I would like to end by saying that avoid any unnecessary medication, assess safety for each trimester, prioritize evidence-based decision, collaborate across care team, no more A to X letter grades, focus on the nuanced evidence-based summaries, and check all 3 sections while prescribing women of childbearing potential, and prioritize on shared decision-making. Involve the patient and the family in whatever the knowledge you have. Having said that, it is not a perfect world. We do not have the evidence, or we do not have the data for everything, but we are providing you with the data which is available for a shared decision making. So thank you very much.
That was excellent, Aparna. In fact, to be honest with you, I wasn't aware of the PLR. So that has opened up new horizons now for all of us to access all information about drugs, which we so freely prescribe to our people, to our patients rather. So it makes us more, correct in our approach to pharmacotherapy. Thank you very much.
Thank you, ma'am. Thank you.
Are there any questions from anywhere?
Just wanted the website, ma'am. I've just put it DailyMed. That is the one for categorization. So that was the only query there. So I put it in. I think there is only a suggestion, ma'am, because all the talks are excellent, but I think they want some time for maybe the seniors to interact and give some discussion. So I don't know how to build that into the webinar time, but that is something which we might have to have a little bit of talk about.
I'll tell you, Srimati, I'll tell you how to modify the things.
Yes, sir.
Before that.
Yes, sir. Otherwise, I don't think.
Dr. Aparna Sharma, as you know, I am a big fan of you. I talked to you earlier also. Really, KSOGA is honored by your presence today. As just now, Dr. Jyotika Desai told, it was a PLLR rule was a real it's an eye opener for all of us. Still, I heard that that ABCD has been stopped using, and PLR I was not very much aware of that. I think most of us got a new knowledge about the today's talk, and really we are honored by your presence today. Thanks for joining. Thanks, Dr. Jyotika, for convincing you to join today. I know how much trouble she has taken.
Lot of convincing.
Yeah, I know.
Thank you.
This is Aparna. This is the new thing we are having. We are giving the platform for the juniors, and it's getting the best out of every society. every junior from every society should come. 4 people will come every month, and they will be judged by 2 stalwarts, Jyotika and Sundari Madam, and one outsider, always one good academician from outside. And this will be assessed the whole year. Things will be done, and they'll be assessed the whole year, and prize money will be announced at the end of the year. That's how the things are going.
Very
This
nice.
my
Very
yeah
nice.
yeah it's my brainchild, and I wanted a platform for the juniors. Thanks for coming, and all the participants today. Thanks for, you have done an excellent job,
Yes,
Madam
thank you.
Jyotika.
Aparna, I wanted to ask you, are you all practicing PLLR in AIMS?
Yes, ma'am.
Yeah, since when?
Yes. Yeah. So basically, what we follow, it's a book called the BRICS. So there's a pharmacology, the books which is drug safety in pregnancy. So it gives the 4 criteria. But before this, what I'm telling you is that I got enlightened because I did not know it is so easily available freely on the net.
Yeah.
So because we had to refer to the book, but now we know that it's just because of this, I shared that link on the chat. Any tag you put, you get the whole information so easily. I think that's the advantage. Yeah.
So
it's very useful, ma'am,
happy
because
that you took up the talk.
Yes.
It's very easy, as Dr. Aparna said, because we recently had one who was an FC direct acting antivirals, and then we put it there. Everything comes at the click of a button. It's very easy to counsel the lady as well, ma'am.
I know.
It's there for quite some time, PLLR.
Yeah.
Good, yeah. All of them very well. So we are very happy today that we got a very
Sundari madam's input, please.
Yeah, I have done, yeah. It's wonderful anyway. Everything was good. All the 4 participants they have done, and Aparna's talk is excellent. As President said, Jyotika said, it's very excellent. I think we know it for quite some time. PLLR is there, but we are not practicing, Dr. Aparna. I think we are still with A, B, C, D, and X. So I think probably we have to change now. Probably we'll be changing it. And I have to say that it's a learning for me also. I enjoy every second Tuesday joining this webinar, and I enjoy it. And so many things I learn thanks to our president.
Yeah.
Yes.
Dr. Durga
Thank you.
Jyotika
Thank
for
you,
also
Sundari.
including me.
Thank you, Sundari. Thank you. Yeah, I'm here because Shobha is not able to come. Shobha Bembalvi is not able to come. She is busy. And I must appreciate Aparnam for her consistent efforts at.
Shobha.
Hello.
Yes, ma'am.
Can you hear me now?
Yeah. Can you hear me?
Yeah. So thank you, Aparna, for being here today. It's nice to see you on KSOGA platform. We were used to being in Foxy. Now it is KSOGA, and I think you are in the right place at the right time, because Dr. Durgadas's initiative this year is really, is so inclusive. And I must tell you that in 2018, when we conducted our annual program in BSOG, we had a full-length panel discussion on PLLR. And Sundari is right that PLLR has been there for a long time, actually.
Yes.
Dr. Uma Devi also joined the panel, and both of us had brought in the concept of PLLR, but then it doesn't catch on. So it probably requires more conversation around it. And you brought that in very well today. So thank you for that. Thank you for that. And I thank the brilliant idea behind this by the President, Dr. Durgadas, and the conveners, Srimati, Dr. Jyotika, and Dr. Sundari, for being here. All the speakers did very well, though I could listen to only 2 of the talks. We had our own webinar in BSOG today for WPD, so I was not able to focus all the time here. But I will listen to the recording, and I will catch the entire talk of yours, Aparna, because I could not hear the entire one. So thank you, everyone, for being here.
Thank you, ma'am.
And make KSOGA grow from strength to strength. And this is only one milestone which is happening. There are several others which is crafted by Dr. Durgadas. And I think Aparna, make some plans to come to the annual conference as well, to Tumkur. It's very close to Bangalore airport. And see that,
Yes.
give your willingness, and Dr. Durgadas will tell you your assignment. Yeah.
It's conducted in Tumkur. Tumkur is hardly 70 kilometers from the airport, just 1 hour, 20 minutes drive. It's the state conference will be on 31st of October and 1st and 2nd of November. Will you please show your acceptance to come?
I think I'll put her in a spot.
Yeah. We have stalwarts like PC Mahapatra, Bhaskar Paul, and
The problem is, I'll tell you the problem, Dr. Durgadas. AOGD is such a replete organization in itself. You know, they have so much work and so much activity. Actually, their annual program is, even more dense than the AICOG.
Ma'am, I'll take this opportunity to welcome everybody.
Do that.
AICOG 2026. AICOG 2026 in Delhi, and I hope to see all of you there. So I think that's the run up to AICOG 2026.
No, if you come to KSOGA, you can invite many more people.
Definitely.
Just think over. Just think over. You'll be very much pleased.
Yes, definitely.
Just see your dates if it is possible.
Yeah. On that
I'll be in
positive
touch
note,
with you through
yes, sir.
Jyotika Desai. Okay.
Yes. On that positive note, sir, let us end this webinar. And thank you very much to everyone. Thanks a lot. Thank you.
Okay. Bye-bye.
Bye.
All of you. Thank you.
Thanks, Durgadas and Srimati.
Thank you.
Agree, of course.